All right, to all who are new here, welcome. Due to COVID-19, we have moved our regularly scheduled in-person journal clubs to an online platform. Fortunately, our fearless head of the journal club and liaison with the BOC, Brittany, has been working diligently to ensure that we are able to provide these educational opportunities successfully. We have over 250 athletic trainers registered for today's webinar. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. For all athletic trainers who are intending to get live CEUs from the BOC immediately after the webinar, please complete the quiz, which will become available once the webinar has finished. In order to access the quiz, you must remain in the webinar until it closes. 1 hour after the webinar concludes, you will be emailed a link to the evaluation and assessment. You will have 24 hours to complete the assessment. Once you've completed the quiz and the assessment, you will receive your statement of credit via email within the next 2 weeks. This is a free webinar, so we do appreciate your patience as this process is taking up to 2 weeks. If you have any questions during the webinar, please submit the question and we will review those questions, as many as we can get to, at the conclusion of the presentation. So I'm thrilled to introduce our speaker today. Dr. Eliot Hu is a sports medicine physician at the Naval Hospital, Camp Pendleton in California. His undergraduate and medical school training were at UCLA and Drexel, respectively. He has been very involved in the ultrasound training with AMSSM, as well as the education, practice, and policy and fellowship committees. He has completed research in dry needling for the treatment of medial tibial stress syndrome and is very passionate about the topic. I'm looking forward to his talk today on an introduction to dry needling 101. So I'm going to switch over so that he is going to then be the presenter, and I'll let him take it away.
Wonderful. So hopefully everybody can see this. You guys should. All right, so welcome everybody. Thank you. Let me see here, something just messed up here. Okay. Thank you for coming to listen and inviting me to give this talk. Dry needling is something that is a passion of mine. I picked it up during my fellowship year. Have been doing it ever since as well. And wherever I have gone, I'm always up for teaching athletic trainers, physical therapists, whoever it is who are interested in this topic. So I think a brief introduction is needed for dry needling because we need to understand what it's for. We need to understand how it's done and what are the potential pitfalls from this, just like any other procedure that we do out there. So without further ado, let's get started. So first of all, nothing to disclose. I am a federal employee of the government, and so everything that I say, does not reflect what the Navy Department of Defense or the United States government has to say about this. So here are the objectives. We're going to identify why we do dry needling, what the purpose of is, and describe some techniques and pitfalls for this. So first of all, what is dry needling? Dry needling basically is an acupuncture needle that's inserted into the muscle and as a treatment modality to control subacute myofascial pain, muscle pains. This is not acupuncture. It does not follow the meridian. So even though we use acupuncture needles, it does not follow the philosophies of true traditional Chinese acupuncture. Sometimes, as you can see in the picture provided, you can see that electrical currents are run through these needles too. The whole purpose of this is that instead or on top of potentially releasing the muscle, we're running currents through it to induce the muscles to contract or relax, running conduction potentials through there to better facilitate what the muscle can do. So who can do this? This is why you're all here. Something just happened here. Let's see. Okay, so who can do this? Obviously, physicians can do this, physician assistants, nurse practitioners, physical therapists, athletic trainers, anybody that you can think of in the healthcare industry. But the important thing to consider is that, yes, everybody can do this, but in order to get reimbursed, you have to be certified in acupuncture in your specialty. So certain healthcare professionals, like massage therapists, they're not able to get certified in acupuncture. so then they can't reimburse for this. Other clinics have done it in a way where athletic trainers can do the dry needling, but let's say the physician or the physical therapist has to co-sign, and they are the ones who are credentialed under acupuncture or certified under acupuncture so that they could do this as well. So, a lot of this has to do with the clinical side, the money side of this, but some of this has to do with, why and how certain clinics are set up. But certainly, athletic trainers, you can do this. When I was at Yale University as the head team physician, I taught all of my athletic trainers how to do this, and they operated under my license, and we were able to do this. So what's the purpose? Relieving pain, obviously. It can be very, very helpful in relieving culprit pain, where this is the primary pain generator, or even victim pain, which is the secondary pain generator. Let's say you have misalignment of the lumbar spine due to muscle tightness or muscle imbalance. And so what are you treating with the dry needling? If you put the needles in the muscle, is it necessarily the scoliosis, or is it the muscles causing pain? Or which one is the culprit, which one is the victim? That's what you have to kind of decide on. But either way, it'll control the pain. We also use this to improve range of motion. If we put acupuncture needles into a tight muscle, what we do is we try to release that muscle, and we improve range of motion and also control pain that way. We can also decompress to areas of tightness, or a secondary victim of this would be nerve entrapments. So let's say the common peroneal nerve is entrapped right as it goes over the head-neck junction of the fibula. The peroneus longus and brevis muscles start right there as well. So if you put a couple of needles there, potentially it releases those muscles, improves the range of motion, and it relieves the stress or the compression onto that nerve as well. So we talk about locations. You can pretty much dry needle any muscle or trigger point that you want. I would highly recommend that you stay away from nerves, you stay away from tendons or ligaments. The reason being that the fibers of the nerves and tendons and ligaments are closely packed together. So one, it's very, very difficult to get a thin acupuncture needle through that tight fiber bundle. And the second reason is that when you try to do that, it hurts a lot. So with muscles, the fibers are a little bit more spread apart, and with trigger points, you can absolutely release those. Deeper structures are accessible as well, as long as you have a longer needle. So if you imagine I want to put the needle into a specific muscle, let's say the obturator externus, it is a deep muscle, and so if you use a really short needle, you're never going to reach it, and so basically you're not really achieving the purpose of your dry needling. Sometimes ultrasound has been introduced in this as well. I know at the Big Sky concussion conference for athletic trainers, or sports medicine conference for athletic trainers, they have started to do some basic ultrasound training, ultrasound workshop for athletic trainers. And so ultrasound can assist in this location. I do have to caution that ultrasound is highly variable due to skill, and also highly operator dependent. And so these are really thin needles, so your skill has to be pretty good in order to see them. Also, this depends on, like we talked about with ultrasound, provider comfort and skill level. The more practice that you do, the better you're going to get, and the more comfortable that you're going to be in dry needling deeper and quote unquote more dangerous or potentially more technically difficult areas. So what's the technique? There's many techniques out there. The way that I got taught was first you mark the location with a pen. You clean the surrounding skin, obviously you don't want to risk infection. And then usually you use a tube, a small tube to put the needle, and then you don't necessarily have to hold on the needle and try to drive the needle through the skin and into the muscle. You can just tap it in. When this happens, my experience has shown that, or in my experience, the patient will typically tell you, yeah, you hit the spot. Sometimes you can even get a twitch response in the muscle to confirm that location too. Now, this is where technique can kind of differ between providers. Some providers leave the needle alone just, after they put it in the muscle. Some piston it for about 20 to 30 times. But the general consensus is that after you leave it in there, you remove it after about 4 or 5 minutes or so. What's the length of the treatment? It really depends on your patient response. Typically, it's 6 to 8 weekly sessions or 6 to 8 sessions in general before you say, yeah, is it really going to work or not? Some patients, they improve, they hit a plateau, and then you say, okay, yeah, you probably hit the maximum benefit of dry needling. Some of them keep improving even after 6 to 8 sessions, and you keep going after that. There's really not a lot of evidence out there to determine what is the length of treatment. Now, this picture is of Seth Smith. He was an outfielder who played for the Rockies, and when he was with the A's, he is known for his speed, and he is usually a leadoff batter. Now, when he was playing for the Oakland Athletics, he did a column with I think it was one of the newspapers out in Northern California. He talked about dry needling as maintenance on his legs. So, certainly on top of acute treatment, subacute treatment, chronic treatment, it could also be used as maintenance. What he used it for was basically to release the muscles so that he would get more range of motion, more flexibility of his lower leg muscles so that he can actually use them and maintain his speed and try to prevent injury that way. So let's talk about some adverse effects as well. Obviously, there's bleeding. Usually, when you apply the acupuncture needles in a highly vascularized area, because of the small size of the needles and relatively thin diameter of the needles and how flimsy they are, they usually will just roll right off of the blood vessels. You won't risk bleeding out or a huge hematoma. But certainly bleeding can occur, usually a couple of drops, and that's really about it. But certainly, if you are the patient or anybody else is concerned about, hematomas, you would always tell the patient and inform the patient first. Pain, neuralgia are potential adverse effects too. I always tell patients that this is not a comfortable procedure, especially if you're having chronic pain already. It's going to feel incredibly sore afterwards. It's kind of like a hard workout, maybe even feeling like delayed onset muscle soreness. And when the needle goes in, and when you start pistoning it, you are breaking up the fibers or you are trying to release those tight fibers. And so it is going to be a painful procedure. Infection is pretty rare out there. This is why we always clean the skin before. But there have been reported cases of infection out there, although it's rare. Pneumothorax, organ perforation, doesn't mean that it can't happen, but they're relatively rare too. Mostly because of the small size, the small diameter, and the flimsiness of those acupuncture needles. Potential pitfalls now that we're going to go over. Obviously, placement is a potential pitfall. If you don't know what you are dry needling, or if you are uncertain, anatomic location, needle depth, all that comes into play. So the example that I gave was of obturator externus. We can talk about, well, if I wanted to dry needle, let's say the quadratus femoris, deep down in the deep gluteal space, you need a longer needle for that, and you need to know exactly where that quad femoris is before you put that needle. Otherwise, one, you'll miss, two, you're causing pain in other muscles and not really achieving the effect that you want. Referred pain and other pain generators can potentially fool you too. So physical exam, evaluation, history and physical, diagnostic studies, all that is important before you offer dry needling to the patients. I see some providers, they say, oh yeah, I think it's this, but we're just going to dry needle anyways. Sometimes they get fooled from referred pain. I've seen a cancer pain referred all the way down to the hip, and I got referred to dry, or the patient got referred to me for dry needling, and I was like, yeah, it doesn't really sound like it. We found the cancer, and after the cancer was removed, his pain went away. So sometimes referred pain, other pain generators can come in. And this is all about, figuring out, well, is this truly the culprit or the victim? So you have to understand that. Know that dry needling can help with either pain, but if you don't fix the underlying cause, then the pain's just going to come back. And the example that I gave earlier was, somebody has scoliosis causing, spinal misalignment and then muscle imbalance after that. If you're putting acupuncture needles into the multifidi or the erector spinae group to treat that victim secondary pain generator, yeah, it'll help control their pain temporarily, but what's the culprit? The ultimate culprit is that scoliosis, and if the scoliosis is severe enough, and that's fixed, it could potentially take away a lot of that victim pain afterwards as well. So to conclude, we're going to go over what's ultimately important in dry needling as a quick summary. Obviously, anatomy is really important. Know what the muscles that you are targeting. Know what muscles are the potential pain generators, whether that is the victim or whether that is the culprit. Alignment, orientation, depth, origin, insertion, fiber direction, where the tendons are, all that is important and as a part of anatomy. We talked about how I highly don't recommend dry needling nerves, tendons, and ligaments. One, because they're difficult. Two, because they're incredibly painful. So if you hit one of those nerves, or if you potentially try to dry needle a tendon, one, the patient is really going to be in pain, and two, they might lose trust in your abilities as well. Biomechanics and the kinetic chain of the body is important too. Hip, spine, basically up and down the kinetic chain. As we all know, that's really important in terms of prevention, in terms of treatment. And so don't forget to treat the underlying cause. Practice is important too. When you take a course, make sure you practice the skills that you've learned, because practice makes permanent. I wouldn't say practice makes perfect, but practice makes permanent, and even better, practice makes perfect. That's what I would say. Official certification and credentialing. This is kind of beyond the education of dry needling, and this is kind of the practical and realistic aspects of dry needling. Why do you want to do this? We want to provide reimbursement for the clinic. You want to get reimbursed for what you do. And so this is why getting the official certification, credentialing, potentially partnering up with another provider who has the credentialing, who has the licensing for this, in order to generate the reimbursement that you need for your clinic is important to consider as well. So here are 3 of my references as well. I know I went through this kind of fast. I wasn't meant to be in detail, how do I dry needle these deep structures. It's an introduction to why dry needling is done. It's an introduction into the basic techniques of it and touching base on the potential pitfalls and why we do dry needling in the first place. So thank you for your attention. I'm happy to answer any questions.
All right, so we have questions coming in here, and the first one is in regards to if you're aware about the state-based certifications for dry needling, the state-based regulations regarding the dry needling.
Yeah, so that's a very good question. There are national criteria as well, and then the state levels, and even sometimes even the county levels have them too. It varies from state to state. I would say, in the state of California, dry needling is limited to physical therapists. It's limited to occupational therapists. It's limited to physician's assistants, nurse practitioners, and physicians. Athletic trainers can take a course, but they're not going to get the certification or the licensure for it. So a lot of us here in California in our sports medicine clinics, we still hire athletic trainers. We still let them dry needle. It's just that they are, using my license, or they're using another person's license, and we're co-signing their note to do that.
Okay. How do you prep the muscle group for the dry needling treatment? Do you heat or warm the muscle?
Yeah, so that's a good question as well. There's not a lot of evidence-based consensus for prepping the muscle beforehand. So I've done it in multiple ways. What I usually do is I don't have them prep. I basically have them come in and I clean the area up, identify the muscle that I need to dry needle, do the procedure, and then afterwards I will have them put a heating pad on there for about 20 minutes or so. What I found in that experience is that it relieves the pain a little bit of the procedure. It relieves the soreness a little bit as well. And then I say, yeah, take it easy for the next 24 hours or so. Take a hot shower that night, and that will tend to relax the muscle a little bit. I have seen other providers pre-prep the muscle beforehand with heat or with stim or even with some stretches beforehand. But I mean, all that, dry needling is an adjunct. It's not a definitive treatment. It's an adjunct to the rehab, to the stretching already that should be done. And so, the way that I see it is that, if they're in pain, if I can control their pain, then they could do their rehab a little bit better. But there's absolutely no evidence-based consensus out there in terms of pre-prepping the muscle.
Are there any certain programs that you would recommend for getting certification in dry needling?
Yeah, so it varies from state to state because states will oftentimes recognize, one organization versus another. I can't speak to, the various 50 different states. I know that, some colleges, some athletic training programs, or even some physical therapy programs will offer dry needling courses, and you have to obtain a certain amount of CEUs in order to get certified for that, but that differs from state to state.
What about age limits? Do you have any preferences on how young you would go, in terms of who should or shouldn't get dry needling?
Yeah, that's a good question. So again, there's no evidence-based consensus for this, but obviously you wouldn't do a toddler, you wouldn't do a newborn baby. Kids are incredibly flexible anyways. And so I have performed dry needling anywhere from about 13 to 14 years old, all the way up to 90, 98, 100-year-old patients as well. My cutoff personally, this is without any evidence, my criteria personally is about 13 to 14. Because what I found is younger kids, they're more flexible anyways, and the whole point of dry needling, one is to control pain, two is to release those tight points anyways. And so I wouldn't necessarily do anybody younger than 12.
And then there's a couple questions here about needles. How long are the needles? How do you decide length? How many do you use a session? Have you ever had a needle break?
Yeah, so to answer that last question, yes, I have had a needle break, and that was in an incredibly tight gluteus muscle. Needles bend sometimes too, and so with those incredibly tight muscles, yeah, they can bend and they can break too. So you do have to be careful with that. The needles typically are 30 gauge. They are acupuncture needles. They're incredibly flimsy, and the length really depends on what you want to achieve. If you know your anatomy and what I realized over the years of doing dry needling is that by doing dry needling and by practicing dry needling, it has provided me with the education and enhanced my understanding of anatomy and actually my sensory functions in my hand. I can actually feel those muscles a little bit better. And it's just maybe a subjective thing. I'm not saying that there's any evidence to that. But sometimes, what I realized was, the more that I did it, the better and more confident that I got in terms of my physical exam and in terms of what I can feel underneath my fingers. Now, to choose the length of the needle, it depends. Like I said, if you wanted to do obturator externus, that's a pretty deep muscle in the groin. And so typically on ultrasound, where we see that is usually about 3 to 4 centimeters down deep. So 3 to 4 centimeters, if you change that conversion to inches, that is about 2 inches. And so that's the general length of the needle that I would use. Now, in a deeper structure like quad femoris or obturator internus, those are really, really deep, and depending on how much adipose they have in that buttock region, I usually will pull out a 6-inch needle or even an 8-inch needle, no problem, and just go right in, just because I know how deep that potentially can go. So it really depends on where you're doing the dry needling, what your comfort level is as well. But the typical diameter of the needle and the gauge of the needle is a 30 gauge, and it's pretty flimsy. It's an acupuncture needle, and just be careful because when sometimes you'll be surprised. Sometimes I'll feel like it goes in and then you pull it out and the needle's bent already.
Right. So there's been quite a few questions about the anatomical locations that you find to be more frequent culprits. Essentially, are there areas that if you address them that they're more successful than others, or high value locations?
Yeah, absolutely. So buttock is is a big part of the referrals that I get in the buttock. Hamstrings are a lot too, especially if you ask Peter Bruckner in Australia. He is a big glute and hamstring dry needling guy. Lower back is pretty common. Upper back is pretty common too. Less common areas that I get referrals or I see for people to dry needle, obviously the lateral elbow, medial elbow in baseball players. Sometimes they do that in the leg, in the calf, even though, there's no evidence for dry needling in the treatment of chronic exertional compartment syndrome. Theoretically, logically, it could potentially make sense. I have done it in those patients, and it was, I believe, an N of 6 that I've done now, and it's a 50-50 shot. And so half of those patients got better, half of those patients didn't make a difference at all. So I would say for the most part, in terms of where I've seen success for dry needling in the muscle groups, upper and lower back, buttock, and hamstrings.
All right. Now, is there, when you are placing needles, is there a certain amount of needles that you might place?
Yeah, so when I was first taught, what I was taught was, you put the needle in and then basically you go about 1 centimeter apart. You map out the area that, the patient has the most pain, and then you put the needles 1 centimeter apart. And I was taught the way to piston it as well. Now, over the years, I've gotten away from that because what I realized is, once you have a needle in the muscle group that you really want to target, you don't necessarily need that many in there. So when I did my research study on dry needling for medial tibial stress syndrome, what I would do is I would put it in that deep posterior compartment. Initially I would put them 1 centimeter apart, all the way up and down the entire medial tibial border of that tibia. And then patients said it was incredibly painful. And then I got away from that, and within a couple of months, I've gone down from 1 centimeter apart. I moved to 2 centimeters apart, and found that that patients tolerated it even better, and the effects were still the same. And then I started saying, well, if we can go 2 centimeters apart, why not go 6? And then so I tried 6, and then patients tolerated even better, and still the same results. And then now I just put one or anywhere between 1 to 3 along that tibia border, depending on which muscles I want to target. What I found in that research study was that the highest amount of shearing forces on that medial tibia, and this was confirmed in a Japanese study, I believe several years ago, was actually the flexor digitorum longus, and not the posterior tib, and not the gastrocsoleus. And so what I ended up doing at the very end of that study was just 1 needle in the FDL and see how that does. And patients actually do respond pretty well to just that 1 needle in the FDL. Now, whether or not that's confirmable, that's up to more further studies to be done. But what I really gained from that study was I don't necessarily need 5 or 6 needles in order to achieve what I need to achieve. And so if you know the anatomy, if you truly think that it is one muscle, typically only 1 needle is needed.
Now, how many times a week would you dose needling? And how many days would you say would be a minimum between sessions?
I would say on a personal opinion, I would say once a week, minimum. And so we talked about 6 to 8 sessions. However you spread that out, that's up to you. I know some people who do 2 or 3 sessions a week. I know some people who do 1 a week. I know some people who do once a month. It really is up to you and the patient to kind of decide that. The only thing that I would recommend or caution against is that dry needling effects do wear off. And so once you loosen up the muscle, once you release the muscle, it will tighten up again. And that's when I tell patients, yeah, if it tightens up, you let me know how many days it takes before it tightens up. I wouldn't do it on a daily basis. I wouldn't do it on an hourly basis because of the soreness that comes. And you have to let the muscle kind of recover as well. And so the most often that I've done is every other day or 2 or 3 times a week for about 4 to 6 weeks. And the least that I've done is once a month for about 4 months or so.
There's another question here about the risk of needle breaking in terms of whether that risk can increase if you're asking them to do range of motion while the needle's placed.
Yeah, so that's a good question because how do you know that your needle is actually in that muscle that you're targeting without doing some sort of exercise? And so these needles, even though they're flimsy, they don't break that easily. And what I found was that where they break is actually where the plastic meets the metal. and not actually the metal itself. And so it actually takes quite a bit of force for the metal to kind of bend and break in the middle. And so typically, what I do is, what I found is when I put the needle in there, if I really need to confirm, only a little tiny bit of minor range of motion is all you need to kind of test out and confirm where that needle is. So let's say in the posterior cap, if you want to make sure that it's in the gastroc and not in the soleus, or if you want to make sure that it's the posterior tib and not the FDL, I would range their ankle just a little bit, have them wiggle their toes a little bit, see if the needle, the plastic part of the needle moves. If it does, and in the proper direction that you're putting the needle, or you're expecting the needle to go, then you achieved what you wanted to achieve. Now, testing range of motion before is important, and then also testing range of motion after is important too. But all that I do after the needle comes out and before the needle goes in, because just like the question is asked, I don't want to risk the needle breaking in mid range of motion.
Now, how about the correlation with rehabilitation or exercises? If they're going to have a treatment session done, would you recommend doing it at the beginning of rehab or after?
Yeah, that's a really good question. So obviously dry needling, what we talked about was this is an adjunct to the rehab that we are going to do. This is supposed to A, control pain, B, improve range of motion, 3, and C, release the potential tightness points or trigger points out there. So it really is up to the individual to decide that. If they can say, some patients say, yeah, no, I can tolerate the pain, and at the expense of the pain, if I gain a little bit of more range of motion and I can do the rehab a little bit better, then they will push through to do that. So oftentimes with those patients, what I'll do is I will do the dry needling first and then send them off to rehab with our athletic trainers or our physical therapists. Some people say, no, it's too painful, I just can't do it. So then they will do the rehab first, stretch everything out, basically a quote unquote pre-prep of the muscle. And then I'll do the dry needling after that as well.
How many days before a competition would you put out the dry needling so that they're not sore during competition?
Yeah, so that's a really good question. At George Mason University, when I started this research project, it actually originated from an elite level high jumper. She was a basketball player, a varsity basketball player first. And then basketball season finished, then she went on to do track season, or track and field season, and then was our only elite high jumper. And so she had to do that competition, but she had shin splints. And so I said, okay, well, let's try this and see. There's no evidence for it. She felt better for about 24 hours or so afterwards. She did get soreness for a couple of hours. And so the shortest amount of time that I've ever done for her was 1 day before the competition, because I don't want to risk, number one, bleeding, number 2, infection. I don't want to risk her having incredible soreness right before her jump. So I would leave this up to your patient and leave it up to their body to tell you, how often or how early you should be doing this or how far apart this should be, because they can tell you. If they say, yeah, after 2 or 3 sessions, the average relief that I get is about 2 or 3 days, and it usually comes on 2 hours afterwards, then I would go off of that. But if they say, oh no, I'm sore for 2 or 3 days afterwards, and then I get the relief for about 1 or 2 days, I wouldn't do it until 2 or 3 days before, or 2 or 3 days before the competition.
What about what have you seen as benefits when you compare pistoning versus needling with e-stim?
Yeah, so needling with e-stim, basically, you're running through that electrical current, and you're basically causing the muscle to contract too. And so that's a little bit different, because if you're stimulating the muscle to contract, you're not necessarily breaking up the scar tissue manually with the needle yourself. So the needle is in one place. What you're depending on is you're depending on the muscle to contract and potentially moving that needle elsewhere as well. And then what you're also doing with stim is that you're trying to improve the efficiency of the conduction through that muscle too. So e-stim with dry needling versus dry needling and pistoning, I believe, are 2 different things. What I'm doing with pistoning is actually breaking up the fibers and the connections of the fibers myself. not necessarily improving the conduction. I'm basically inducing a little bit of damage in the muscle and then giving the patient and that muscle a chance to recover on their own rather than doing their own conduction electrical current through there as well.
Do you notice that the pain gets worse before it gets better, or do you typically get immediate results?
So an important question that I ask the patient, and I provide this as a caveat to the patient as well. I always tell them before, I say it is incredibly painful, but this pain is soreness, and this is kind of like quote unquote good pain. Bad pain is typically what they feel. And so immediately afterwards, I ask them to quantify how much of the bad pain still remains. And what I found in my experience is that most of these patients, I would say even more than 70% of them, they come back or immediately after the procedure, they say, yeah, it's all good pain, it's all soreness. My bad pain is either completely gone or it's significantly better. I wouldn't say that, a lot of my patients come out of a procedure immediately painless. I would say, yeah, a lot of them come out with good pain, and very rarely do they get results from it. If they have basically no improvement from it, then what I'm doing is I'm thinking about it and I'm saying, well, did I make the right diagnosis or not? Is this the true pain generator or not? Or is my needle in the right place of where I want it to be? That's when I kind of go back and reevaluate.
So what are some major side effects that you have experienced while performing the dry needling, or that patients have experienced, whether that's dizziness, syncope, nausea?
Yeah, so that's a good question. Usually with a pain response, you are going to get some sympathetic responses as well. Just like when we do corticosteroid or even trigger point or diagnostic injections, some people can pass out because of the procedure itself. Some people can pass out because of nervousness. Some people can pass out because they're dehydrated, hypoglycemic, whatever the cause is to that sympathetic response. I've never had anybody pass out from dry needling. Doesn't mean that it can't happen. And it's certainly reasonable and logical to think that, yeah, with an intense pain response, they can get dizzy, they can get nauseated as well. This is why with dry needling, I typically do it when they're laying down or in a safe location. I never do it when they're standing up. I usually never even do it when they're sitting up unless it's in the elbow. They can sit up for the elbow with that. But usually in the buttock and the back, I usually have them lay down.
Do you have any contraindications for doing it?
Yeah, obviously active infections or skin infections, cellulitis in that area. If they're immunocompromised severely, and there are multiple medications to cause that immunocompromise, I wouldn't say that that's an absolute contraindication. That would be a relative one for me because they are more prone to infections. Obviously, if they say, oh yeah, my port for chemotherapy is right there, and you want me to dry needle there, I probably would think twice about it. In dangerous locations with, let's say, the brachial plexus, the anterior, middle, and posterior scalenes, pec minor, I would be a little more careful. They would all be relative contraindications, not necessarily absolute. Especially if I have the ultrasound. I've done that under ultrasound guidance many times. The other part of this is, an absolute contraindication for me, at least personally, there's no evidence for this, is that if they have a history of drug and alcohol abuse or any sort of secondary gain from this, that they say, oh yeah, I'm just here to control my pain. I just want my pain meds. I want to check this off my list. What I found is if the patients are not committed to this, if maybe a placebo effect, it may be a lack of placebo effect, then typically they don't do that well.
What about pregnancy?
Pregnancy, I have done dry needling on a couple pregnant patients around their sacrum as well for that pregnancy-related back pain. I found that to be pretty successful. At least in family medicine, there have been textbooks and some procedures out there talking about free water injections there, basically to provide kind of a neuroprolode lift-off technique in that area too. And so I have done dry needling in that area. I wouldn't say it's an absolute contraindication for pregnant patients because number one, you're not injecting anything. Number two, yeah, it's going to mess around with their their muscle alignment, it's most likely going to release some of those muscles. But if they're asking you to do it on their bellies or do it on their abdomen, where their uterus is and you can feel the kicking, that's a relative contraindication to me. I mean, I would probably put the ultrasound on there before I put an acupuncture needle there.
Now, how about in the post-operative patient? How soon after surgery would you consider doing it, if you would consider doing it?
Yeah, so I have done that in the past too. Post-operative patients, there have been some studies out there, not necessarily for dry needling, but for scar mobilization and for scar minimalization as well. So I have done it just in that scar tissue too. I technically coded it as acupuncture dry needling, quote unquote, but it was basically scar mobilization, scar minimization. And so there have been studies done on that with pretty good reports of success. So I have done it on post-operative patients. Obviously, I wouldn't do it in that immediate post-op week afterwards. And it's really dependent on the comfort of the surgeon too. So you always have to work with your surgeon and say, well, when do you think I can do dry needling? I think it will help release some of the muscles. If the physical therapist or the aesthetic trainers recommend it, I would touch base with the surgeon first. But I've done it, the quickest that I've done was about 3 days post-op.
Now, in terms of dry needling for headaches and migraines, do you use dry needling in those circumstances, and how might you explain what's happening?
Yeah, so a lot of the headaches and migraines that I see when I was in private practice, and even now in the military, they're due to concussions. And most of them, I would say a good portion of them, have some sort of cervicogenic origins to their headaches and migraines, whether that is the greater occipital nerve, the lesser occipital nerve, or the least occipital nerve. So what I've gone after in terms of dry needling there would be the rectus capitis posterior major, would be the obliquus capitis, and then also the splenius capitis and semi-spinalis capitis too. So I've seen pretty good results from it. That's not to say that I haven't seen any failures from it. Some people just don't respond for whatever reason. But for the most part, a lot of my patients who get dry needling for headaches, usually I will put the needles in that posterior neck, and most of them do get some sort of relief from it. Some of them get significant relief, some of them only get partial relief, and then we work together with pain management, neurology, and physical therapy, and really to rehab all that.
All right, so there's a couple of questions here kind of getting back to, we were talking about athletic trainers in certain states are not allowed to do invasive procedures, including EpiPen injections, sutures, and whether there might be other certifications so that they could potentially wear another hat while doing the procedure. And then there was also a question about dry needling at the high school level in California specifically. Yeah. Should that person talk to their team physician? Or what might you suggest?
Yeah, so like we had mentioned before, certification it's different on various state levels. So it's really important for you for athletic trainers to find out, well, what can and what can't I do? Certainly, if it doesn't say acupuncture, you could take an acupuncture course and start dry needling yourself as well. So if it's not allowed by the state, doesn't mean that another provider can't be certified or credentialed in acupuncture, and then you take a course, and then you're performing under their license with their co-signature on it. So that's typically what we talked about in the past or previously, how you can do this. Certainly, you don't want to be violating any laws. So I would double check with the laws. I would double check with with NATA to see if there are any recommendations from their end. In terms of at the high school level, specifically in California, we know that I know that the athletic trainers are not allowed to do dry needling or acupuncture. And so certainly if you wanted to do it, a lot of what we do at the high school levels is in the training room anyways, and it's not technically quote unquote a clinic. I would say, yeah, typically those patients who I have done for high school athletes, I would bring them back to the clinic and find the provider who is credentialed and licensed in acupuncture so that you can properly document you can get the code signatures and you can get reimbursed for what you do. You never want to go into a high school system and offer one kid one thing and then not offer another kid one thing, because then you can potentially get into trouble there.
How about pairing needling with cupping? There's a couple of people asking about if you did cup somebody already, would dry needling still work? And then also in terms of ordering cupping with dry needling, and then maybe some of the manual therapies with whatever manual therapy, like let's say for example iStim and the massage. What order might you do those in?
Yeah, so I'm a big proponent of all those adjunct therapies. There's no evidence in terms of combining therapies right now out there. That's a good study to do, a good systematic review to conduct as well. But I am certainly a big proponent of doing all of them, sometimes even combined. I wouldn't necessarily put the cup on there and then dry needle afterwards, because they're going to be incredibly, number one, incredibly vascularized in that region, and number two, incredibly sore. But I would combine them. There wouldn't necessarily be an order. It really depends on how much discomfort the patient, number one, is willing to tolerate. Number two, how much discomfort the patient actually feels. And so if patients come to me and say, yeah, I had cupping, and then I don't care if it being highly vascularized, if I can get down there with a needle and even into the deeper structures, then I will do it in that region. With iStim, eStim, you can do that, concurrently, or even before and after too. There's really no order that I would recommend in doing those. But the only thing that I would say to that is, you need to consider how your patient feels and what they're comfortable with. And so if they're saying, yeah, it's a muscle here, and you want to do dry needling with eStim with cupping, come up with a plan with them. And I would say, explain it to them how everything works, and think about it logically. Because if eStim is going to improve the conduction and it's going to contract the muscles a little bit, and that's what you're trying to do, and you're trying to get that contraction and that tightness first in order for it to relax, you may not need to do dry needling afterwards, because now you're breaking up the fibers, you're breaking up the conductions through that muscle. So same thing with cupping as well. You're cupping, so what you're doing is you're improving vascularization to that area as well, which is basically what dry needling is going to do anyways. So do you necessarily need to do dry needling on top of cupping at the same time, or even immediately before, immediately after? So I would think through that logically. There's no recommendation out there to say, oh yeah, specifically you need to go from A to B to C. What we're all trying to do is we want to get the patient from the point A to point D, but which path you take over there, it's relatively up to you and the patient to decide.
Is there an official gold standard for which dry needle to be using?
Unfortunately, there is not. Dry needling has been around for a very long time, but there's no quote-unquote gold standard. Like I said, there's varying techniques for this, but the idea of it is still the same. So the whole purpose of it, the rationale for it, they're all the same, but the technique can be very, very different.
And what is the general cost?
Yeah, so acupuncture needles are really cheap. So the cost of this is basically, how much you're willing to shell out for acupuncture needles. And I think a pack of 100 needles was like $3 or $4 for me to order through the clinic. And it depends. Obviously, the longer length needles are going to be a little more expensive. The shorter length needles are going to be less expensive. And there are other brands out there, differences in brands. But from what I remember of the finances in my clinic, usually they're anywhere between $3 to $10 per box, and you can get a box of 100 to 150 or even 200. So it's relatively cheap to do this. For the patient, if they have insurance, like I said, if you bill it correctly under a provider who is properly certified, properly licensed, and credentialed, then usually it's a pretty profitable modality to have in your clinic as well.
Now, would you perform dry needling to reduce swelling in joints?
I would not. So I don't believe the purpose or the rationale of dry needling is to decrease swelling in joints. Now, I might dry needle the muscles around it so that, if compensatory tightness happens or compensatory contractures happen, then we can certainly put the acupuncture needles there to potentially release that. But I wouldn't do dry needling as a primary purpose to relieve swelling of a joint.
Can you utilize dry needling with muscle flossing or nerve flossing?
Absolutely. That's kind of sort of the technique that we use with pistoning too. But certainly you can combine those as well.
Okay, and there are a few research articles discussing superficial versus deep dry needling for myofascial trigger points. And as some have stated, the superficial myofascia communicates or connects with the deep myofascia that helps to ultimately get the desired effect. What has been your perspective on interpretation of the literature?
Yeah, so I agree with that. As we start to understand more and more about myofascial pain, and especially with John Liftoff, with his Liftoff technique, what he does is he does these subcutaneous injections to take away pain, chronic pain. And so I truly believe that. But I also believe in, if I wanted to accomplish and target a specific muscle, my inclination and my logic is I have to put the needle into that muscle. But I haven't done any studies on that, and there haven't been at least many studies out there looking at the difference between superficial versus deep, other than those research studies out there. There's only a few, and so somebody has to replicate it as well and confirm it. But I certainly agree with that mindset. If we can figure out that, hey, if we're just doing superficial and it works just as well as deep, then maybe we don't need to do the deep.
Right. Well, that looks like we've hit the vast majority of the questions here. So I'm thrilled, and thank you so much, Dr. Hu, for allowing us to do this. I am going to remind everyone that the 1 hour after the webinar concludes is when you'll be emailed the link for the evaluation and the assessment. So that will not come immediately. That will come 1 hour after the eval, the assessment. All right, and thank you very much. I'm gonna conclude this webinar. Are there any last things that you would like to share with everyone?
No, thank you for all that you do. Athletic trainers are, I truly believe in the abilities of athletic trainers. They make my job and all of our jobs a whole lot easier. You are our eyes and ears out there as well. So thank you for all that you do.
Great. Stay safe, everyone. Stay healthy. Everyone be well.
Thank you.